So it's great to see everyone connected. We have over 80 participants joining, and yes, so this is, as I was saying, warm welcome to everybody. This is the 16th meeting of the global meeting of the Working Group on Public-Private Mix for TB Prevention of Care, or the PPM Working Group of the Stop TB Partnership that WHO hosts the Secretariat for. We are very pleased all of you can join us in these very difficult times. Thank you for joining us. So let's dive right in. We have a very exciting lineup of speakers, and we'd like to begin the opening session by first giving the floor for welcome to the director of WHO's Global Tuberculosis Program, Dr. Teresa Kasayeva. She has been a PPM champion since she joined WHO and has really helped in pushing this agenda forward here in the organization. So very grateful to have you here with us, Teresa. So over to you, and then we will go to the chair of the PPM Working Group, Dr. Madhu Karpai. So first over to you, Teresa.
So thank you very much, Monica, distinguished colleagues, partners, and friends. I am pleased today to welcome you all to this important global meeting on public-private mix for TB prevention and care working group, along with my very good colleague and friend, Dr. Chair of this group, Dr. Madhu Karpai, and two excellent vice chairs, William Wells and Lal Sadasivan. So a warm welcome to all our distinguished lineup of speakers for today. You are all very powerful voices, respected voices to find to NTB and in this specific area of public-private engagement. As Monica has told, indeed, and we all know that these are very difficult times for all of us, especially as we grapple with the deadly new COVID-19 variant that has us all concerned again. But in the same time, we have some positive news. Probably many of you followed this historical World Health Assembly over the past 3 days with the unprecedented unanimous support by all the member states of the WHO joint efforts to fight this new virus, new pandemic, and unanimous agreement to conduct new mechanism. And first, it will be decided by the intergovernmental body, and it is called now Convention on Treaty. We will see, and it of course opens new opportunity. And I hope not only to combat COVID-19, but also combat tuberculosis. So that's why, despite of all the challenges, we have also opportunities. We have to learn lessons, and it's time for this work. Yes, it's clear that the impact of the pandemic on TB has reversed years of progress. For the first time over a decade, according to our 2021 Global TB report, we can see increase in TB deaths, and it's very, very concerning. The number of people newly diagnosed with TB and also dropped from 7.1 million in 2019 to 5.8 million. So WHO estimates that some 4.1 million people with TB missed out on access to care or have not been reported to national authorities. It means that we have big questions, even if they manage to have access to diagnosis and treatment, how it has been provided, what was the quality of care. And we know that disruptions are ongoing. We're collating data on monthly basis from more than 100 countries. Unfortunately, these trends are continuing, and we can clearly see based on our modeling, that it unfortunately may lead to further increase in TB-related death and incidence in the coming years, 2021, 2022 especially. So that of our great concern. And of course, these trends, we can observe the similar trends in all the sector, both public, private, but in all care providers. We are comparing disruption of TB services also with other communicable disease services, and it's obvious that impact is much more significant on TB, and including allocation of human and financial resources. So that's why I think that it will be extremely important these 2 days look at the challenges and opportunities of the private care providers and other providers beyond public sectors, and to look at the best practices, what could be learned, what can be taken immediately on board. So this is exactly the best time, and I know that you are very busy. Thank you for your dedicated time, and I hope that this meeting will be extremely useful and fruitful. So the purpose of today's PPM working group meeting is fourfold. We will review global, regional, and national progress in prioritizing PPM to close gaps in access to prevention and care services, including through the rollout of the PPM roadmap. Share best practices and innovations in private sector TB service delivery in the face of COVID-19 pandemic, discuss ongoing efforts to strengthen PPM monitoring and accountability, including through data dashboards, and chart the way forward and identify key priorities for the PPM working group for the coming year, including for the preparations to the 2023 UN high-level meeting on TB. Now, our discussions at this meeting today and tomorrow will be really essential, vital to provide inputs to guide national programs. And all our discussions and efforts are under the umbrella of broader multi-sectoral engagement and actions. And now we can see, especially nowadays, that this approach, multi-sectoral approach, will be definitely the way forward if we would like to come back on track faster, and if we would like to bring additional resources so much needed for our TB response. So, and if we would like to protect those suffering and dying from TB. So the clock is ticking. We know it's very well and not in our favor, and so that's why let's brainstorm and think what we can do better, faster, different way. Of course, it's clear that business as usual is not working in the current circumstances. So once again, thank you very much, and wish all of us a successful meeting. Hand over back to Monica.
Thank you so much, Teresa, for those powerful and inspiring words to kick off the meeting. I'd now like to turn to Dr. Madhu Karpai. He heads the Global PPM Working Group. He's been heading it for the past few years. Madhu, your leadership has been quite vital in driving the PPM agenda forward. So over to you for some welcome remarks.
Thank you, Monica, Teresa, and colleagues. It's amazing to see 100 people join for a TV meeting, given all the craziness and chaos over the new variant. I was supposed to go to India next week, and I had to cancel because of all the new travel bans and restrictions and everything that's exploding. If you had told me that we would be having our second pandemic meeting of the working group last year, I would have laughed at it. But now I worry that we may well have next year's meeting also in the middle of a pandemic, because we are allowing new variants to emerge and failing miserably in vaccine equity globally. Teresa, Soumya, and I were asked to contribute an article on how does TB recover from this COVID damage. And we identified vaccine equity for COVID as our #1 priority. If we do not vaccinate the world, we are doomed. And TB will suffer and continue to suffer in the years to come because we just can't go through more and more of these surges and waves. So we wrote a piece in Science magazine last week, even without knowing the new variant, and we titled it Vaccinate the World. That's exactly what we should all be advocating for, because our future in TB is tied to ending this pandemic. I cannot imagine any situation where TB will magically recover if the world gets hammered with new variants and new surges in high burden countries. And it's the low and middle income countries that are now bearing the brunt of this pandemic. Data clearly demonstrates that COVID is way more deadly in low and middle income countries than it is. The death rate is much, much higher in the global south. And the pandemic is now coinciding very clearly with high burden countries. That's where the damage will come from, and that's where the vaccination coverage is low. So we all have to obviously work on TB, but we also have to raise our voice and say this vaccine inequity is unacceptable to all of us. This vaccine apartheid must end, and we have to demand world leaders to do better and support WHO's call for TRIPS waiver, for donating rapidly to COVAX, for not hoarding vaccines, because without ending this COVID pandemic, I fear that the TB fight we are losing it. Next year's TB report will be worse than this year's, because this year was all about Delta, and Delta was substantially worse compared to 2020. And I don't know what this new variant will do in 2022. So please work hard, not just on recovering TB services and offering TB services, which is critical, but also to convince everybody around you to become an advocate for COVID vaccine equity, because our collective future depends on it. Thank you so much.
Thank you very much, Madhu. Indeed, looking at the big picture, yeah, wouldn't imagine that, we're at the next working group meeting and we're on, I don't know which wave of the COVID pandemic, and it's getting scarier and scarier. Let's hope for better times in 2022. We've been in hope, and absolutely agree with your call for vaccine equity and working together to address both TB and COVID. Thank you for that. So now with that, we'd like to turn to one of our distinguished opening speakers. We are very pleased to have with us Ms. Handa Enk Amgalan. Handa is a TB survivor. She originally from Mongolia. She's right now working in Kampala as a program coordinator at International Rescue Committee. She works with refugee populations, and she's a best-selling author. She's written a book called Stigmatized. We're very pleased to have her here with us to share her unique experience, her journey dealing with TB in Mongolia, which has just joined the high burden country list this year, and to hear her call for action. Over to you, Handa.
Hi, everyone. Thank you so much, Monica and Dr. Madhu Karpai, and also Teresa for having me in this discussion opportunity. My name is Handa Enk Amgalan, and as Monica mentioned, I'm from Mongolia. However, I'm currently based in Kampala, serving refugees and host communities. Let me start my speech with my story. When I was 15 years old, I was diagnosed with pulmonary tuberculosis in my left lung. I was only 15 years old at that time, and consequently, I was hospitalized for about 2 months and continued on with antibiotics for extra 4 months. So a total of 6 months of treatment to fight tuberculosis and overcome it. The day I was diagnosed is actually very much connected to private hospitals and also public hospitals, and the dilemma that that we all face when it comes to private healthcare and public healthcare, and how can we further promote the intersection and why. So the day I was diagnosed, I was walking with my mom in the middle of the street, just visiting our aunt. And all of a sudden, I experienced very sharp chest pain, which caused me to fall down in the middle of the street on my knees. I couldn't breathe. It was really hard to take even a small breath. I thought I was dying. My mom, who was with me, was very scared, of course. And we both knew that we had to go to get my chest checked out, perhaps getting x-ray done. However, we both knew that going to a public hospital would actually take at least a month to get an appointment and get an x-ray done, and then get an x-ray done and then get the results back in time. By that time, I get an appointment, get my x-ray done, I would have probably died, which is why my mom decided to make a tough decision. She pulled out her wallet to see if she has enough money to take me to a private hospital. Unfortunately, she had only $1, which was dedicated for buying food for my siblings, for me, and for my parents. Of course, my mom decided to choose health over food. Nobody has to face this decision, this tough choice between food and health. But my family faced this decision, and my mom chose my health. We went to a private health hospital right next to where we were walking. We were met with this friendly physician who took my x-ray. As soon as she, however, a few minutes later, as soon as she saw my x-ray results, her facial expression changed. She gruffly told us that I had TB, and she gruffly asked us to leave and go to the National Hospital for Infectious Diseases, which was the only hospital that treats TB patients, which is the only hospital, and it's public. My mom and I had to travel at least for 2 hours by bus to get there. And once I was hospitalized, my mom had to travel every single day to bring food to me to that hospital, traveling 2 hours in one way, meaning 4 hours in total to travel to bring food for me at the hospital. Let's say if this situation was reversed, right? If we had more public-private partnerships, for example, then first of all, we wouldn't have that administrative burden on public hospitals, right? It wouldn't take at least a month to get x-ray service. It would be much faster because the burden is shared among public and private providers. Let's say private hospitals were providing TB healthcare service delivery. Then that private hospital doctor wouldn't have rushed us to the national hospital that's 2 hours away, which caused unnecessary financial burden on my family for that day, but also 2 more months every single day where my mom traveled to a hospital to bring food for me. So that would have been spared if we had more public-private partnerships. So I would like today to call you all for action to further promote, to further advocate for more public-private models, particularly in developing countries, in high-burden countries, so that we can reduce all these burdens on patients. I was one of those lucky ones whose mom had $1 in her pocket. Let's imagine if there was someone who didn't have $1, what would have happened to that person? That person would have waited for at least a month to get x-ray, and we don't know if that person would be alive, if that person would wait for at least 1 month and even maybe beyond. So let us all get together for discussing public-private partnership initiatives. How can we mainstream this around the world so we can save lives? My last call to action is for you all to also think broader beyond service delivery and engaging perhaps other private actors, right, such as technology companies, to reach more people in hard-to-reach areas. And also leverage corporate social responsibilities to advocate for TB causes. Once more private actors are engaged, then this disease will be destigmatized when everybody is talking about TB, right? Because right now, all responsibility, all pressure, everything goes onto public sector, and it's hidden because there's stigma and nobody's talking about it. So let us all change that with one step at a time, starting with public-private partnership. And I know that today you will all have great ideas to share and exchange. So I wish you all good luck for your discussion, and thank you for having me.
Thank you very much, Handa. Very, very emotional story. No one should have to choose between food and health. Indeed, it's so painful to hear. And now in these times of COVID, with even more economic burden on people, we can imagine how so many people in poverty are struggling. And we have seen indeed an increase in deaths that we reported, as Teresa said, for the very first time this year. So severe impact, very painful story, but you emerged victorious, and it's great to see you, be an advocate for TB, and also an advocate for another population that's vulnerable, the refugees. Thank you so much for your calls to action. The PPM working group will keep this in mind as we initiate our deliberations. That's why we wanted to have you set the scene for us at the opening session. So thank you very much, Handa, for joining us. Thank you for taking time to be here. So with this, I'd like to now turn to other distinguished speakers in the opening session. We have two vice chairs of the PPM working group. We have Dr. William Wells and Dr. Lal. Let me start by giving the floor to Dr. William Wells from the U.S. Agency for International Development, USAID. USAID is the biggest bilateral donor for TB efforts worldwide and a big supporter of PPM efforts over the past decades. So William, over to you as Vice Chair for your opening remarks. Thank you.
Thank you so much, Monica, for your leadership, ongoing leadership of the PPM community, and also to Teresa for your very strong support. And thanks, Handa, for a very brave and important testimony. I want to talk just very briefly about the PPM community, because that's what, every time we gather, that's what I really reflect on, the strength of this community and its ambition and level of innovation. I think it's second to none in global health in general. I mean, just as a short anecdote, thinking about what the Indonesia NTP is taking on in partnership with a USAID project, TBPS. So together, the NTP and the project are thinking through many things. So including interoperability of different data systems. They're working with the data directorate of the ministry to think about how information can flow more seamlessly between public and private and between different parts of the public health system. They're thinking about IT solutions to make that work better and to link up other parts of the patient journey. They're thinking about different purchasing arrangements of how private providers and also public providers are reimbursed by the National Health Insurance Agency to promote better TB care and more seamless TB care. They're thinking about the role of NGOs as intermediaries and how that would work, the role of NGOs as support agencies and how private sector clients would be linked to those efforts. They're thinking about access policies to diagnostics and drugs. How does that work if you have publicly funded diagnostics, and how do they get into the hands of private sector clients? So all of these things being considered at once as this amazing kind of jigsaw and set of solutions. So again, just to close, I thank you all for your efforts as a community. I know in many countries, there are many people tackling all of these issues and coming up with these very creative solutions. And I applaud all of you for that and really encourage our continued work on innovation, which will be featured very strongly tomorrow as well. So thank you again to Monica for organizing the meeting, and back over to you.
Thank you very much, William, for those nice opening remarks, for your support and leadership in this work. Thank you very much. I'd now like to turn to Dr. S.S. Lal. He is Vice Chair, the second Vice Chair of the PPM working group. Dr. Lal is actually leading on political issues in India, especially in the state of Kerala. So, Dr. Lal, over to you. Thank you for joining us.
Thank you, Monica. Good morning, good afternoon, and good evening, dear global PPM friends. On behalf of the PPM Global Leadership, I'm also happy to welcome you all to the 16th Working Group meeting. I too share the concerns raised by all the previous speakers, Dr. Teresa, Dr. Madhu, Monica, and William. And thank you, Handa, for sharing your story, which again reminds us of the great amount of work yet to be done, especially in hard to reach areas, and also the importance of social determinants. Today, we need to quickly review the progress of PPM work that we have been doing amidst this COVID pandemic. We need to deliberate on some of the priority areas and also share some of our experiences, including some of the best practices and innovations from the field where the actual work happens, despite the COVID challenge. As has been already pointed out, COVID has impacted some of our PPM work also. And actually, we are at very precarious crossroads. We need to watch carefully and patiently, but act promptly and correctly to successfully tide over this crisis. Today, we have brilliant and experienced giants in the fight against TB to enlighten us with their wisdom and experience. We have also with us large numbers of PPM experts and supporters from across the world. So it's really great to have the presence of Dr. Teresa also, the global leader of WHO TB work. And so I would like to thank all the international organization leaders and especially Dr. Monica for taking all the pains to organize this meeting in the middle of all the work. The way the work we work has been changing in all the fields, and we have to adapt to this situation. For PPM also, we have to do the same thing. Let's all work together and use our precious time most economically and effectively today. And thank you everyone.
Thank you so much, Dr. Lal, for those inspiring words. Indeed, these are precarious times. We are at a crossroads. We need to, cautiously watch, but act rapidly. Very wise words. So let's, so that's something that we need to look at as we, plan this meeting on and go through. Thank you for your words. I now would like to turn to Dr. Mohammed Yassin, Senior TB Advisor at the Global Fund. Dr. Yassin has also been a great supporter of all the PPM efforts, and the Global Fund has also made a lot of contributions, especially through the strategic initiatives or the catalytic financing initiatives to really help push up to strengthen engagement of all care providers, including the private sector, to reach more people with care. So we're very pleased to have you with us, Dr. Yassin. Over to you for your remarks.
Thank you, Monica. Good morning, good afternoon, good evening, everyone. Thanks for the opportunity. I would probably focus on more highlighting the opportunities from the Global Fund side. As part of the finding the missing people with TB, which has been a great momentum, the overall focus on really private sector engagement has been highlighted, and we have seen a trend within the Global Fund is increased budget and funding for private sector engagement, and also bringing more implementers as principal recipients of the Global Fund funding, and promoting implementation and scale up of some of the innovative approach for private sector engagement. So that momentum means for the last 5 years more funding for private sector engagement through the grant. But through the additional funding opportunities as well, including the catalytic funding, which also incorporate the matching funding for priority countries. That's additional money going to support innovative interventions, including private sector engagement. Also strategic initiatives where we have been working with the WHO and Stop TB, with USAID to support countries to implement those innovative interventions as part of the technical support. And we appreciate the support of a Ppm working group overall as part of this initiative. The scope and the number of countries also increased from 13 to 20 in the current cycle. And the scope also expanded from just focusing on the notification, but providing support along the cascade of TB care, which is it's very important, and promoting, translating some of the pilot project innovative intervention to scale at national level. And countries have been using the global funding for this purpose, including some of the savings and reprogramming, part of the portfolio optimization where you can really bring more resource. As you all have highlighted, for the Global Fund for all the 3 diseases, for the first time we have seen a decline in the results. So including a decline in number of TB notified. Since the Global Fund was established in 2002, that's the first time we have seen a decline in programmatic results report, including TB, due to COVID. And I think we all are part of that problem. Now focusing more on how we can address and catch up, including mitigating further disruption. And we understand that overall the start was slow last year, this year as well, due to the COVID pandemic. That means actually there may be more resource within the grant and more opportunities for reprogramming and to saving more people. And we are not focusing on saving money, it's more on saving lives. So that would be an opportunity for national TV programs and in-country partners to really engage with the Global Fund countries teams to leverage additional resource for further scale up of some of innovative private sector engagement models. As this is an opportunity, and Global Fund strategy encourages evidence-based programming and data-driven scale up of some of the intervention. This is an opportunity to scale up private sector engagement, including outsourcing, contracting, and working with the private providers as partners, including through digitalization of the recording and reporting system, which would be an incentive. As Global Fund also provided additional funding as part of the COVID response mechanism, over $4 billion the last year and this year, to support the key COVID-related response, the urgent ones other than the vaccines, but also to help to mitigate the impact of COVID on the 3 diseases, including TB, and moving to more innovative interventions to address that people receive basic TB service, and also health and community system component. That contributes to additional funding for TB mitigation as well. And some of the COVID response mechanisms are really cross-cutting, including the lab and the community component. And TB would benefit from these interventions, including the infection prevention and controls. So I just want to encourage you again to really explore, and we would be happy to continue working with all in-country partners and global fund partners to make sure that the private sector would receive additional funding, not only from Global Fund, from domestic source as well. Thank you very much. Back to you, Monica.
Thank you so much, Mohammed. A very clear overview of the work that has been done over the years with Global Fund led support, of course, with the partners, and also the various opportunities looking ahead. I think this is really important for the working group listening in to understand what these opportunities are, the opportunity of also leveraging the COVID resources and basically synergizing all of our responses. So thank you very much for those encouraging words. I'd now like to turn to Dr. Jacob Cresswell. He is a team leader, innovations and grants at the Stop TB Partnership. The PPM working group, as I mentioned up front, is a working group of the partnership. And we're very happy to have Jacob here with us today. Jacob has actually led a lot of the work on TB Reach that many of you are familiar with. That's really been critical in piloting a lot of the innovations, including in the private sector. So Jacob, thank you for joining us on behalf of Stop TB, and we look forward to hearing your welcome remarks. Over to you.
Thanks so much, Monica. I'd like to welcome all of you on behalf of Stop TB, and thank you, Monica and Teresa, Madhu, and all of the other speakers. It's a large group. It's great to see people joining and listening. Apologies, my dog wants to come in the room. I think, as Monica said, at Stop TB and specifically at TB Reach, we've been working very hard to support innovative ideas around private sector engagements. You will hear from a number of them during this meeting. I think to build on what Mohammed has said, what we try to do at TB Reach is source innovative ideas from partners in country. We fund them at a small scale, and we work together with the Global Fund and other partners to try to get them scaled up. And thanks to USAID and a lot of work that William has put in, we've been able to fund quite a few private sector engagement projects over the last few years. That as for calls for funding specifically focused on private sector engagement, and we're seeing a lot of great results. The TB Reach projects in general are risky in a sense. Not all of them do wonderfully, but we always have some really impressive and worthwhile results, and try to promote those star projects. And again, I think you'll hear from Luan later today about work that has been done in Vietnam. And really, after decades of private sector engagement work, it's been able to make some great strides that can be seen at a national level. Other work that we've been recently involved in has been focused on pharmacy engagement in Pakistan, and some very promising work that builds off of work that the Gates Foundation supported in India, but working with private drug sales and specifically targeting pharmacies. Huge numbers of people identified that have TB or receiving treatment. And so we really look to document more of these results, to share them with the wider TB community. We hope to, through this work and these meetings, to stimulate ideas and interest. We look forward to new proposals. We hope to have calls for proposals launching next year as well for TB Reach. So we really want to be part of this ecosystem that drives innovation and is able to impact overall notifications and case detection within countries. So very happy to be part of this, and excited to listen to the progress that is being made now. So thank you again, Monica and Teresa, and looking forward to the meeting.
Thank you so much, Jacob. Thanks for your remarks and also for flagging these upcoming call for proposals. There have been several rounds with private sector focus as well, which have really helped drive innovations in PPM. So thanks for all the support as well to the working group. So thanks to all the distinguished speakers in this opening session. It's just to provide the whole group an overview. You can see we have a very, very strong leadership structure in place, and you are with us in promoting all the work forward on private sector engagement. So very grateful to all the audience who have joined. If you have specific questions or clarifications, please use the Q&A function, especially as we move ahead. So now, without further ado, what I'd like to do is quickly share with you, and I know we are behind time, but I'd like to quickly share with you a global overview of the work on private sector, on public-private mix, and the role it plays in accelerating efforts to reach the missing millions. So I know that many new people have joined the meeting today, and this meeting is also being recorded. It's being streamed live on YouTube. Many thanks to my colleagues E and Anna who are helping in the background. So just for those who are new, and bear with me, the rest of you, just to give you context on the Global PPM Working Group very quickly. I've already said it. We are a working group of the partnership. WHO hosts the secretariat. We provide support to countries in collaboration with other partners to enhance collaboration and engagement. And members include NTPs, policymakers, civil society and affected communities, and representatives from private sector, academia, a whole range of international technical partners and development agencies. Membership to the overarching open group, the working group is open, so we welcome you to join us. I will ask my colleague to post in the chat the link to the forum that we have in place where we can exchange ideas and discuss. And here you can see a picture of our last PPM working group meeting that we held during the COVID crisis last year, towards the end of last year. And we hope during the icebreaker very quickly to have a new collage in place with all of you. And we also launched the landscape analysis on private sector engagement. We will post these links. These are key resources that we encourage you to look at. Also to clarify for everyone what we mean by public-private mix. I was very struck in my discussions with some of the speakers because we have new speakers with us today as well. So as we were preparing together, it was interesting to explain what PPM is, also what TB programs are. So just to clarify to everyone that when we talk about public-private mix, it's two things. It's public-public mix, which refers to engagement of care providers who may be in the public sector, like public hospitals, medical colleges, prisons, detention centers, etc., but they are not necessarily linked to national programs. So we don't know what happens to the people who access care in these settings. So we want to make sure that there is public-public engagement as well, so that we can follow through to make sure everyone who accesses care in non-NTP care facilities, non-national TB program care facilities, has access to quality care. And then we have public-private mix, which refers to the engagement of the national program with a range of private sector care providers. This can include clinics, hospitals, corporate business sector, NGO organizations, faith-based organizations doing care delivery. So just a gentle reminder for all of you that this is the context that we look at, and also our focus is quite specific on service delivery, and making sure we have all care providers engaged. So let's just go back into the big picture. The COVID-19 pandemic, everyone has been saying, severely impacted access to care. Fewer people access life-saving TB care in 2020, as reported by the World Health Organization just a little over a month ago. We have the gap of the people who miss out on access to care has increased, and we know that a large majority of these people were actually not reported, and they may be accessing care either in the unengaged public sector or the private sector. Likewise, for those affected with drug-resistant TB, we know that only 1 in 3 of those who fall ill with drug-resistant TB will actually access diagnosis or treatment. And we believe PPM can help close that gap. Another big gap we see is in children. Over 500,000 children and adolescents miss out on access to quality care, and we know that this group of children really, access care mainly with pediatricians, very often, again, out of the public sector or not linked to national programs. So this is another group that we'd like to reach. Likewise, as we look at, the various people that we need to reach, another group is, those who are eligible for TB preventive treatment. We're talking about household contacts, people living with HIV and other risk groups. Again, there are big gaps in this area. We need, we need to really step up engagement, and we need to get all care providers engaged in this effort. There was a call to action issued by WHO and partners. The private sector really needs to get on board to make sure that we can close these gaps in TB prevention. So what, as a PPM working group, what we've been promoting really is that we have a roadmap that we launched in 2018, and this has 10 priority actions. This, along with the landscape that we released last year, an updated landscape, both are critical tools that we urge you to refer to use to look at how we can take PPM up to the next level. So just very quickly to show to you the 10 key priority actions that we have in the PPM roadmap, and this goes all the way from building better understanding, setting targets, using innovations, better incentives and enablers, all the way up to financing, monitoring progress, and building accountability. And as we go through our sessions today and tomorrow, we will be touching upon each and every aspect of these 10 priority actions. We also have timelines and targets, and you will hear discussions around these. For instance, the next session is going to be on monitoring and evaluation and accountability. This is one of the targets that we have very clearly mentioned in the roadmap. So let's look a little ahead to what the contribution of PPM has been to reaching people with TB care. So as you can see, these are the big PPM priority countries. Notifications, PPM has been vital in public-private mix has been vital in basically bolstering notifications. So there have been a lot of contribution in pushing up notifications. Of course, you can see in 2020 in several countries that there have been severe drops. COVID has definitely impacted a lot of the work, especially last year. And you can see that here in this very quick model developed by NIM for us, where you can see in 2020 that there were severe dips, and now it's on recovery. This is looking at aggregate notifications, public plus private. And you'll hear more from NIM tomorrow on this modeling work. But COVID has resulted in increased TB deaths, fewer people reached with care, and fewer resources, which brings us back to also what Handa mentioned about leveraging other resources in the private sector, for instance, to ramp up the TB response. So what do we want to achieve at this meeting? Teresa has already mentioned these 4 key objectives that we have. So what we're going to do through our various sessions is based on those objectives. We're going to be looking at strengthening monitoring and evaluation and accountability. We have, WHO has launched a multi-sectoral accountability framework. We are looking at really getting all sectors on board if we are to end TB. The private sector is really critical. Our work on PPM is quite core and should be at the center of all the efforts around, from monitoring and reporting, review, action, commitments, and actions. The contribution of PPM can help in all of these. And you will hear in the next session a more deep dive into some of the work that we're doing with countries and some of the work that we plan to do in the coming year or two with the Bill and Melinda Gates Foundation, excuse me, on supporting priority countries develop enhanced PPM dashboards to improve visibility into PPM performance and commitment, increase accountability, have stronger TB programs. We will also hear from countries on what they are doing in this area. Going ahead, so the next session will be moderated by Guy Stallworthy from the Gates Foundation. Following that, we will have a core session on addressing PPM in the private sector as part of the antimicrobial resistance agenda. We've just come through World Antimicrobial Awareness Week, where there's been a spotlight on antimicrobial resistance. Now, we all know and understand the links between private sector engagement and its importance to curtail the development of drug resistance. So this is something that we're going to be looking at. Both we will be hearing from a survivor and also hearing drug-resistant TB survivor, and also hearing from Vietnam on some of the efforts that they're doing. Tomorrow, we will have a session led by Madhu, where we will hear from Nim on the modeling work that I gave you a flavor of earlier, but you will really hear more about the modeling of impact and the cost of non-engagement or not doing PPM, how it can impact, and also a range of innovations in engagement, taking PPM and the TB response to the next level. And we have an exciting lineup of speakers. We've tried to get a little out of the box. We will hear from communities, from pharmacies, diagnostics, other new partners. So it's going to be very exciting, looking out of the box. We'll then go into another session, and this links to what Handa spoke about, the choice between having to choose between food and health. I mean, this should not happen to anybody. So looking at social protection, access to care, UHC, and looking along that continuum. So we will speak about, we have Dave Clark joining us, who will speak about the overarching work on universal health coverage, private sector engagement. We have new guidance on social protection that's being developed right now, and we will have Ernesto from our team speak to that, along with Guy Stallworthy. And then we will have a fireside chat with William Wells, who will be leading this session to talk about what it takes to change mindsets to enhance public-private cooperation during contracting. And then looking ahead, the next bit will be about how do we get PPM in the spotlight, especially as we look ahead to reach the UN high-level meeting 2022 targets, and looking at the 2023 UN high-level meeting that's planned. All of these are really high-level, high-level spotlights. How do we get PPM in? And I'd just like to end by reminding you that we had last year a report from the UN Secretary General, where he made 10 priority recommendations. One of them, number 3, speaks about advancing universal health coverage And here very clearly reference is made to the need to scale up engagement and leverage the capacity of private and other unlinked public healthcare providers. So we do have that mandate, and we do know that this is one of the priority actions that can help, kind of amplify, push things forward to help us reach the targets, even with COVID being there in the mix. So this is something, just to put it out there for you, that we need to work on together. And then the last point is, as I said, we are all in the midst of making preparations for the 2023 UN high-level meeting with the Office of the President of the General Assembly, who you see in the middle, with the Office of the Secretary General. WHO has been tasked with, in the UNSG report and in the political declaration, to work with partners to prepare for the high-level meeting. The declaration that comes out of this meeting will be pivotal, as was the previous one. It will be pivotal in helping us really ramp up the response to make sure we reach NTP targets. We need to think together, and we will really look for your ideas on this to see how we can work together to make sure that PPM is featured strongly in all efforts, and how we as a group can contribute to making this a reality and helping countries take efforts to the next level. So with that, I'd like to thank you, and thank you for your attention. So that was a very quick and rushed overview. We are a little over time, but we invite you now to take a quick breather. We have with us my colleague Wong Yi, who's part of the team. I turn it back to you, E. We will do a very quick photo and icebreaker activity. Over to you, E.
Thank you so much, Monica. Greetings, everyone. My name is Wang Yi. I work with Monica at the WHO Global Tuberculosis Program. It's a great honor to be here and to lead you and to invite everyone to join me for a small session. And we would like to take a group photo of everyone. First of all, please allow me to invite all the panelists who are joining us today to kindly turn on your camera. We would like to see everyone to show your faces in the camera. Thank you so much. I can see all of you here. So I also want to invite everyone to just maybe unmute yourself for a second and join me. And I would say, together we will, then I will hand over to you to say NTV. It's our commitment. So let's have a try. I will say, together we will, NTV. Thank you. Let's have it one more time. I will take it, capture this exciting moment. Together we will. NTV. Thank you, everyone. So I think my colleague Anna helped me to capture this exciting moment. For the rest of the participants, I can see now we're close to 100 participants who are joining us now. I'm now sharing my screen. You could see from here on the top left corner, there is a QR code. I would invite you to take your to use your mobile phone or even iPad or any mobile device to scan the QR code and join us at Slido, this platform. And you could see here, you could just tell us where you're joining us from and list your country and list your name and country. I see Monica just joined us from Switzerland. I'm looking forward to see more participants joining us now. Yes, we see Sheshi from Nigeria. Thank you so much. we see more participants from everywhere: Scotland, Indonesia, USA, and Belgium. Great. Welcome, everyone. So for all of you, I will now ask my colleagues' help. Anna will drop you a link in the chat box, and from there you could download the background, the virtual meeting background. You could use it image with on your mobile phone and just to take a selfie of yourself. And then my colleague Anna will share another link. You could just simply upload your selfie to that website, and I will get the picture of you. And after our meeting session, I will make a giant collage, as what Monica showed earlier at the beginning. So to just mark everybody's participation. Thank you so much. I will keep my eye in the chat, and I thank you everyone for joining me for this activity. Thank you so much.
Thank
Monica,
you, E.
hand over back to you. Thank you.
Thank you very much, E, and also thank you, Anna Stukalova, also from the team who has joined and who is supporting. Yeah, so great team effort, and it's exciting to see all the participants from all across the world. I know it's different time zones, so thank you for making the effort to be here, to join, and yeah, and to share your perspectives and listen to us. So without further ado, let us move to the next session, which will be on strengthening monitoring and accountability for public-private sector engagement to NTB. This session will be chaired by Dr. Teresa Kasaiva. So I turn to you, Teresa.
Yes, thank you very much, Monica. So we are moving forward with the second session, and dear colleagues, yes, of course, we will be very focused and specific. We will discuss public-private engagement, but as Monica shared in her presentation, we should always position ourselves as a part of bigger picture, like PPM as a part of broader multi-sectoral actions and engagement, the drug-resistant TB as a part of broader antimicrobial resistant agenda, monitoring and evaluation as a part of the broader, because this is the way we should guide also our programs, countries, and all the TB community, because sometimes we, with our fragmented messages, with the good intentions, we are creating some maybe more problems and confusion to the implementers. So that's why I hope we are all in agreement. Let's follow these principles. So, and I would like now to give a first floor to present TB Ppm Dashboard's accountability for engaging all care providers in Ppm priority country to Francis Mhimbira, colleague from WHO. Francis, floor is yours.
Thank you so much, Teresa, for the introduction. Good morning, good afternoon, and good evening, everybody. Yeah, my name is Francis Mhimbira, and I'm presenting a brief overview of our work here at WHO to develop dashboards to enhance or to ensure action and accountability. And this is for PPM priority countries. So dashboards are not very new, I must say. So if you look at the guide by WHO on analysis and use of health data, which is based mostly on DHIS2, this guide provides 3 objectives, which are, it's actually our thinking towards also PPM, is to first to describe key epidemiological data, but also quality indicators from the PPM space. And also the objective is also to look at what are the key indicators and how do these indicators inform monitoring of TB care and control, but also interpretation of the analysis that comes out of the dashboards. Now, the components, the 4 key components of the guide, which also we think that will also be useful for PPM, is the guide We'll look at data quality, what are our core indicators that we are thinking that are relevant for PPM, and core analysis and consideration for interpretation. But of course, this guide is based on the overall TB care, but our thinking is this could be the approach that will be useful for PPM. Maybe quickly to take you back on the PPM roadmap, there are 10 key priorities for action. And when you think about dashboards and data analysis, the three priorities that are linked to this. So one is we are setting up ambitious targets for PPM, but also we want to also to harness digital technologies, digital innovations to improve data analysis and utilization, but also we want to monitor progress and build accountability. So because of that, we think that there is an urgent need for PPM dashboards. And again, referring to the roadmap, with the dashboards, as they help us with the analysis, we'll be able to kind of monitor progress towards country-specific goals and targets that we have set for PPM. By doing that, it will inform us of our accountability, like how accountable are we to the commitments that we made for PPM. But as we review the accountability, it will also inform us whether we need to review the approaches. So it's kind of a cycle that we think that these dashboards will help us not only monitoring progress, but also improve our accountability as far as PPM is concerned. So quickly, just a bit of challenges that we face in the availability of data, but also quality of data in the private sector. And I've tried to categorize pragmatically into three areas, but there could be more. So one is looking at policies and coordination. So these are the things around mandatory notification. If it's not enforced, then there are issues of underreporting. We look at reporting forms that we have. They might not be very useful for the private sector, issues of supervision and mentorship that might help, that might affect availability and quality of data. And the other aspect of the private sector is actually the electronic TB surveillance system. So they are quite diverse. And already I think there are issues about interoperability between systems, not only in the private sector, but public, and capacity for system integration, especially from the NTP side. But when you look at the scope and quality of data, there are also issues around definitions across indicators, especially for PPM, that they seem to be varied from country to country. And when you look at data, we base mostly on notification of data, but some of the data that is relevant to quality of care of TB data might not be there. So I think our work, we are trying to harmonize all these issues and try to solve this. So we understand that there is a need for PPM dashboards, and we also know that there are challenges. So there is a special initiative of WHO, which is supported by Bill and Melinda Gates Foundation, which actually is to build these dashboards. And in this slide, I'll take a minute or two just to describe our timelines and approaches that we hope to do them between now and 2023 to realize dashboards, especially for PPM priority countries. In summary, we have 5 key milestones. We start, as of today, presenting our concept to the working group, essentially introducing that there is PPM dashboards that we think of. And then between now and January next year, we want to develop a position paper which actually introduces the concept, our approaches, and what are the expected outcomes. Next year, between January and March, we do a series of consultations. This could be either in-country visits or online consultations with the NTP, M&D teams, WHO country offices, in terms of mapping data and indicators that countries are reporting. And from there, we'll develop provisional standard indicators that we would like to have priority countries meet and provide a consensus. And we planned a meeting in April 2022. Essentially, have a consensus on what indicators we want to measure under PPM, what approaches. We'll also have a consensus in terms of our approach of developing dashboards and definitely getting inputs from priority countries and stakeholders. We review on the timelines, and also will provide you a brief of the type of support that countries will receive, which actually is reflected in our next milestone of developing the dashboards, which is, we hope that by the end of 2022 December, we'll have a prototype that we can demonstrate not only to countries, but also to stakeholders in terms of what kind of indicators are there, what kind of analysis we envision will be helpful for PPM program performance. And between May and December, we hope to recruit a consultant who will be based in countries that will be selected for this project to actually support in-country activities, but also through development process will try to learn and also troubleshoot any issues along the dashboards. But also it's our intention also to have part of this work be reflected in the next year's TP report to introduce the dashboards. And in 2023, it's more of a rollout of these dashboards, essentially in the PPM priority countries. We'll also track progress. We'll, as much as possible, learn from the lessons of from implementing these dashboards so that we can either improve how the dashboards look like, but also scale up in other countries. So dashboards in summary, so there are several things that are similar to the previous slide, but just to understand the process of developing dashboards, it starts with the document review. So these are reviews mostly, be it NSP, M&D, or PPM action plan, just to get a sense of what data is there and what kind of indicators countries are reporting. And then we look at the data surveillance systems to describe the actual ecosystem of what is there in the countries, essentially the data flow, what kind of systems they're using, what kind of data elements they're collecting, and how is the flow between maybe the private sector and to the public sector. That means the NTP. We like to align whatever indicators we understand we get from each country to the WHO PPM indicators. So these will be proposed indicators with the standard definitions. And then the fourth step will be to do a consensus building, essentially agree on what to measure and definitions. As I said, of course, we develop the dashboards. Now the platform are quite various, but as of now, we'll agree on the type of platforms we'll use to demonstrate these dashboards. And then the last step is actually to roll out PPM dashboards, which will be supported by the local consultants in the countries that will be selected. So that's briefly in summary, our thinking process around developing the PPM dashboards. So how do the dashboards look like? So the example given actually comes from the guide I showed earlier, and you can have quite a number of analysis you can work with dashboards. I'm sure many of you are aware of this, but just to summarize, within the dashboards, we can do trend analysis, we can do visualization with maps, and then we can do TB care cascade, especially important for different types of private sector providers. And we can also do summary tables. And we think by developing dashboards, the outlook will be that countries will have, choice of platform for dashboards. These are only the provisional ideas. And then also the outlook is also how does these dashboards fits in the global standards, global dashboards. And if we standardize these, then we can be able to compare efforts and performance across countries. We can look at interoperability between systems. We ensure that there is a consistency in definition of the indicators in the PPM space, but also we hope that we'll have more data other than notification data as far as PPM is concerned. So, of course, dashboards are being built by indicators. This is just a list that not exhaustive, but just to get a sense of the categories that we are thinking of. In the lines of finances, engagement, coordination, indicators related to service delivery along the TB care cascade, and even the using of electronic TB surveillance platforms among the private providers, and also we're interested also to look at the accountability part based on the multi-sectorial accountability framework that provides several indicators along commitment, actions, M&B, and review. So just an example, for instance, in engagement, we might be interested to look at how many private health facilities are engaged in a particular country based on the targets, so we can really easily measure this through these dashboards. So, of course, as I said, the list is not exhaustive in terms of these indicators. We'll go through a series of consultation with countries and stakeholders in order to come up with a list, and we hope we do this agreed by next year in April. Just to point out, because these dashboards, we want them to improve our accountability, and just to refer what Monica has also presented, is on the multi-sectorial accountability framework, which I must say, we are happy to also showcase Kenya's public-private mix action plan, which have actually included some of the multi-sectorial accountability framework indicators, which I think will be useful once we have this dashboard, so that we know that how accountable are we. Just two more slides. So this is our proposed implementation arrangement. It's in 3 levels. So we have at the global level, regional and national level. And at the global level, we have the WHO HQ, which leads the whole process, but also working with a working group and also global partners and civil societies. And our role will be to coordination and oversight, but also providing technical assistance and also track progress based on the milestones that we have set. We hope that our regional offices, WHO regional offices, will also help in terms of coordination and oversight. But most importantly, at the national level is actually to the NTP and the country offices and partners, including the local consultants, as I've said, coordination, but also the actual doing work of testing and rollout of dashboards in the countries that I've selected. And as we think about developing dashboards, there are some key questions that we might need to reflect. One is what type of data that needs to be managed in country to give PPM focus. What are the challenges of systems and interoperability? And these would vary between countries based on the systems that exist in those particular countries. And we also want to think about how does this work, the work that we want to do on dashboards, fits in the global dashboard systems, and what are the contributions of the dashboards to the global accountability framework. So because everything is tied to the accountability, and how do we achieve consistency in definitions between countries? What is desirable and what is possible? And the last question that we think as we develop the dashboard is what is the balance of current and aspirational goals in PPM. So that's my last slide. Thank you so much for listening. And that's a bit overview of our work on dashboard. Thank you. Back to you, Teresa.
So thank you very much, Francis, for excellent comprehensive presentation. Now I would like to give floor to our close partner and collaborator, well known to you, Guy Stolworthy. He's leading the work on public-private engagement in the Bill and Melinda Gates Foundation, and he will be moderator over the roundtable on strengthening monitoring and accountability for public-private sector engagement. So hand over to you, Guy.
Thank you very much, Dr. Teresa, and to Francis for that excellent introduction to this topic. At the Gates Foundation, we're delighted to be supporting WHO in this work. I think we can all agree that we know that TB programs are working hard to improve quality of all sorts of data, and certainly the current COVID crisis has really highlighted for everybody the importance of data in achieving our objectives. But I think we can also all agree that TB-PPM has been a field that has some particular challenges in this area, and in many respects, quite a long way to go if we are going to be prioritizing it as much as we have said in our commitments. So Francis has done a great job outlining this initiative that WHO is going to be leading for the next couple of years to improve the quality and the availability and the comparability of the data on PPM as a way to increase visibility into the performance and also increase accountability and not so much vertical accountability, but also between peers and between country programs, and all with a view to stronger TB programs. So now we're going to have a session with 5 speakers from countries with very significant private sector role in their healthcare systems, talking about the current PPM programs and the indicators and accountability within those programs. This is a great way to start this effort. We're going to be focusing perhaps largely in these presentations on current data, but as Francis indicated, over the next couple of years, we can all aspire to do much better and to get richer data in this area. So without, and I hope we'll have enough time to have a discussion both amongst the panelists, but also with questions from the rest of the larger group of over 100 people. And so please do post your questions in the Q&A, and we'll try hard to make time to discuss them before the end of this session. So without further ado, I think we'll move to our first country presentation from Kenya, Dr. Wendy Kirote, if I pronounced it correctly. Please, over to you for your presentation.
Thank you so much, Stolworthy. I believe you can see my presentation.
Yes.
All right. Thank you so much, Teresa, Monica, and the Global TB PPM Working Group for always availing this platform for us to learn from, and we are excited to be part of this. So allow me to share a brief overview of the implementation of PPM activities in Kenya. So to begin with, sorry about that. Monica, you can possibly share a slide because I don't see if it's working.
Okay, E, can you share slides, please?
Yes, Monica, I'm doing it now.
All right, I see mine are not moving still. All right, so as I was saying, I'll just share a brief overview of the implementation of PPM activities and how we've been monitoring our activities of the PPM in Kenya. So the mission of the TB program in Kenya is to engage our private providers towards finding the missing people with TB. And in 2015, 2016, we did a prevalence survey that showed that we were missing nearly half of our patients, 40% to be specific. And these patients that we were missing, most of them are males, and those that are in the urban setup. And in addition, those who are also HIV negative. We also saw that our current, at the time, the screening and testing modalities were not quite sensitive to be able to find all the missing people with TB. And we've done quite much to be able to change this scenario in Kenya. We also saw a lot of challenges in the health-seeking behaviors of TB patients. Individuals in the communities with TB symptoms who are not seeking care, or those that present to the facilities, especially the private facilities, not being able to, being diagnosed with TB because the symptoms they present with are not recognized as TB symptoms. In addition, we did a patient pathway analysis in 2017 that showed us that majority of our patients, nearly 42% of our patients actually, first visit the private facilities, either formal or informal private facilities. Next, please. So along the way, the National Strategic Plan plans to meet all these people who are seeking care everywhere in the system. And our health sector is comprised of 48% of private facilities. So we continually see opportunities within our sector to engage the private facilities. And along the way, we've engaged nearly 15% of these facilities to provide TB services. So providing either screening, testing, or offering treatment for TB services, and they are able to report through our national platform called TB. As I had mentioned earlier, we saw that 42% of our patients with symptoms first seek services in the private sector. So we have had a lot of active engagement of the private sector towards recognizing these symptoms through capacity building, provision of diagnostic modalities within the private sector so that they are able to diagnose these patients the moment they first visit the facilities. But with the prevalence survey, we also saw that 21% of our patients from the prevalence survey also sought care within either the community pharmacies, the private clinics, and the chemists. And we've had a lot of engagement of the community pharmacies and the chemists towards screening and referring this patient and linking them to possible diagnosis or treatment. But we have had a gap in that nearly only 7% of our facilities, the private facilities, that are able to adequately diagnose TB, but through various interventions, through Stop TB, TB Reach, and Global Fund, we've been able to expand diagnostics within the private sector through hub and spoke models. Next, please. So over the years, we have had quite some increase over a period in case finding since 2016, after we did our prevalence survey. And the contribution of the private sector has been on average 20%, but we are now beginning to see a decline, both in case finding in the country, as well as the contribution of the private sector. But one thing that is notable is that we have seen quite a lot of increase in the referrals that have been made from the private sector to the public sector, either for diagnosis or linkage to treatment. Next, please. So we have the National Strategic Plan that hopes to meet all our patients wherever they seek care. And with this, we also developed the Ppm Action Plan 2021 to 2023 with an hope to create a more inclusive and sustainable partnership to engage the private sector. So one thing that we target is we emphasize on creating commitment and promoting a positive role of the private sector, to champion for progressive approach towards inclusion of the private sector, as well as the diversity of the private sector. Within this action plan, we came up with 5 service delivery models that we hope to be engaging to moving forward. We have the private sector, the institution, and the individual provider model. We also have the diagnostic model that is encompasses the lab and the imaging. We also have the pharmacy and the chemist a model that we will be creating some hubs and spokes for them to be able to either screen and refer these patients for diagnosis. We also have our workplace model where we hope to reach people at their workplaces and bring services closer to them, especially the men, because we know they have a greater burden and they have quite some poor health-seeking behavior. So we hope to reach them at their workplaces. We also have the informal service provider model. As we earlier saw, we have a lot of our first engagements or our first encounters, either the formal or the informal service providers. And we have prioritized some key interventions that we hope are going to help us within this action plan find our missing people with TB. We have outlined quite some great mapping strategies and selection of providers to engage, including mapping their gaps so that we are able to effectively plug into their areas of needs, customize and designing some reporting tools that are specific for the private sector and that are easier for them to use, including establishing patient-provider network models for the private sector to be able to have a network that can pool resources for them to collect samples or refer patients to a nearby facility where they can seek services, but also send their samples so that we are providing a faster diagnosis for them, irrespective of where they seek care. A lot of continuous capacity building and training for the private sector. It's quite vibrant sector and quite fast moving. So we have to keep moving with them and have mechanisms that are adaptable to them. And we have some quite lessons learned during the COVID-19 from the private sector that enabled us to reach them through virtual platforms that we're also hoping to expand. We also hope to establish linkages and referral systems, both for the patients and for samples, so that to be able to bring the public-private partnerships closer, as well as expand the contact management within the private sector, including provision of the TPT. We have expanded some quite incentivizing models for the private sector. We all recognize the autonomous nature of the private sector and the fact that it's a business, there are business opportunities there, and incentivizing them to help us find these missing cases, but in addition also work together. Then frequent data reviews and support supervision for the private sector. This is something that we have prioritized under this PPM Action Plan 2021 to 2023 to be able to help us visualize our data better and use it for decision making. We have also some quite innovative ways, models to capture data within the private sector that I'll be talking about next. We have had some gaps in reporting within the private sector. In an assessment we did as we were developing the PPM Action Plan, we saw tools that are available in the private sector but are not in use or are totally not available, significant underreporting within the private sector, and tools that are within the private sector but are not customized for their use. So it makes it quite challenging for them to adapt to what we are looking for or what we intend for them to report on. Then we have a lot of electronic medical records that are available in the private sector, but are most focused on accountability and sales. So within the PPM Action Plan, we have an objective to promote the effective and efficient monitoring of the PPM interventions. And one of the things that we have is an application, both app and web-based Tibulite system that is creating an ease through shared devices of healthcare workers to avail screening modules, recording and reporting modules on personal devices. And we have already started rolling these out in the country. That is also going to provide linkages between the private providers and the community, including monitoring of treatment, provision of TPT, and reminders to the patients for them to come and collect medicine, as well as provision of an easier method for self-training within the app. We also have prioritized the Ppm Dashboard that's Dr. Muhimbira spoke about, to enhance optimization of visualization of data, so as this to increase the demand and use of the data, and also to support regular collecting of PPM data to have this flow of this data, including outcomes that we can be able to view effectively for the private sector. And also ensure the information that is available inform key gaps and decisions under PPM intervention. Next. We also have some, next please, some sustainability mechanisms that we have proposed in the new action plan, the accountability and sustainability mechanisms, some of the enabling environments. We have some policies and frameworks to engage the private sector, including the multi-sector accountability framework that is providing a lot of avenues for accountability for different sectors, but also for the private sector towards TB control. We have a lot of tools, diagnostic tools, capacity building, commodities, and towards creating an enabling environment for the private sector. Some financing modalities and strategies for the private sector that are specific to different models for us to be able to create efficiencies. Then bringing all stakeholders for the Ministry of Health and other stakeholders through the multi-sector accountability framework to be able to respond to TB activities and TB altogether, as well as the incentives that I spoke about to the providers to be able to increase their participation in it. But also we have a workplace policy that we are in the process of finalizing to also ensure that we have the workplaces also participating in these and creating the accountabilities in ending TB, as well as the multi-sector accountability framework. That is it, and thank you so much. Back to you, Stolwe. Thank you.
Thank you very much, Wendy. That's an excellent overview. I was particularly impressed by the use of data, the understanding of the patient pathways, and also your quite rigorous data on the proportion of private healthcare facilities that are actively reporting and offering different services. So we'll watch that with great interest as you implement your plan. So we'll turn to Indonesia now. Dr. Tiara Pakasi, over to you for your presentation, please.
Okay, thank you, Chair. Monica, would you please help me with my slides? I'm having connection problem with one of my devices, so I'm switching to another device and I cannot share the file from my other device.
Sure, sure, Dr. Pakasi. It's being shared.
Yes.
And if you can mute one device, that'll be helpful for the sound.
Yes, I already muted one of my devices, and I'm sorry I cannot turn on my camera because the connection is very bad here. It's quite difficult for me to switch on my camera. I hope it's okay. So
no problem.
Yeah, thank you. So Dr. Teresa, Dr. Madhu, and all the PPM working group, Monica, participants, ladies and gentlemen, very good evening from Indonesia. I'm Tiara Pakasi. I'm the NTP manager in Indonesia, and I'm pretty new in this TB control family. It's my 5th month now in TB program. So yeah, for Indonesia, I think I will start with a background before I start the presentation. So everybody might have been aware that Indonesia is one of the high burden country, and until now TB is one of the biggest public health problem in Indonesia, as we know from the recently published Global TB Report 2021. The estimated cases of TB in Indonesia is 824,000, and also we still have high of mortality, and yeah, I think one of the country with the highest incidence rate, right? So and before the pandemic, the COVID-19 pandemic occurred, actually we already identified challenges in TB program. in which it was the notification from the private sector is very low or pretty low compared to the notification from the public sector, public facilities. So while on the other hand, the most of TB patients seek for healthcare starting through the private sector. So with this, I think PPM is very relevant and crucial to be implemented in Indonesia. However, we need to increase the capacity of the private sectors, and also because the private facilities are very large in Indonesia and sometimes fragmented, and sometimes they do different approaches for TB treatment, etc. So PPM really important and crucial to be implemented in Indonesia. So I think PPM already started here in Indonesia for quite a while, with ups and downs, of course, but thanks to all partners that are working very closely with us at the NTP. So yeah, it works. It works. So in this slide, I would like to show that the pandemic impact. So I need to switch from one device to the other. I'm sorry for this inconvenience. As mentioned also from the previous speakers, I think three biggest impact on are the declining program in the performance and also services. Also, the second one is increased burden for the health workers, because as mentioned, I think it was by Dr. Madhu, that we all need to be participated in tackling the pandemic. So that includes our TB health workers. They participated in the tracing and also in the vaccination. So yeah, the burden was quite high, and they were pretty overwhelmed by the additional burden. To be added to that, they are facing stigma against them by the communities, because everybody thinks that they are in close engagement with COVID-19 patients. So happen in some, not maybe now it's getting better, but at the beginning of the pandemic, many health workers are facing stigma, and also they're facing fears, because of the lack of the PPEs issue, and also about the mortality that was quite high among the health workers in Indonesia. And the third impact was the reluctance of the patients to visit health facilities because of the hoax and disinformation regarding COVID-19. So they prefer not to visit the health facility. And we know that if they're actually suffering from TB, then the transmissions are going on among their close contacts. Next slide, please. So here I would like to show some figures showing the notification in Indonesia, TB cases. We can see that the green color showing the public sector, public facilities, and the blue one is the private one. So we can see that the contribution is very low from the private one. And during the pandemic, we can see that there is a significant decrease of notification in Indonesia. And the year of 2021, it is even worse than 2020 so far. Next slide, please. In the middle of this situation, despite of those challenges, yeah, we are quite encouraged and have our motivation back, because our president has promulgated this presidential decree on TB program last August. And with this, we were reminded that, yeah, it's not only COVID-19 that is happening in Indonesia, but we also have TB that needs to be tackled. And what is good from this decree is that it really clearly stated the highest commitment of the government of Indonesia to achieve the elimination of TB in 2030. It contains our national strategy and also the targets, and also it clearly divides the responsibility of the national or the central government and also the province and district government. And it is very relevant in the Indonesian context because health system in Indonesia is decentralized. So if it's not mentioned here, maybe during this critical situation, local government would not pay or give priority to TB program. So with this presidential decree, it is quite like a light in the darkness for TB program after during the disruption of COVID-19. So in this decree, it is also mentioned again about the mandatory notification of all health facilities. So it is also really relevant with the PPM strategies. So following up to this presidential decree, now that the COVID-19 is pretty how do you call it, controlled in Indonesia, and the vaccination rate is quite high, and so we can start to recover for TB and start to accelerate again our pending activities. So I think for the short period in 2021 that we still have, we have two priority to do the active surveillance and also to do the active case finding. For the active surveillance, of course, we do because we know the underreporting issue in Indonesia, we do the data validation at the primary health center, and also for the hospitals, we do the mopping up. And this again, if PPM doesn't work, I think this cannot work either. And for the active case finding, we do the with the education also at the population, and also we start doing the TB symptom and X-ray screening also at the population. And also, of course, we try to enhance our existing contact investigation and TPT administration. That was quite hampered by the social restriction and also limitation of activities during the highest or the peak moment of the pandemic. So we need to recover, and we have to do this together, and with the presidential decree that really mandated all multi-sectoral and stakeholders involvement. This we pretty optimistic that we can recover and catch up. Next slide, please. So regarding the public-private mix, thanks to the hard work of all elements and NTPs with all the partners, even though we have to do online calls, we haven't met each other like physically, but we do have these strategies developed, for public-private mix. If we can divide it to points, we have 8 points of strategies. they are, number one is to strengthen the network and coordination mechanism of all health facilities. This consists of the internal network and also external network. And for the second one, we try to improve the quality of TB service by promoting the implementation of the ISTC and other regulation to all professional organizations in order to increase the capacity of the members. And also we do have, or we collaborate with the National Hospital Accreditation Committee, like to put TB service as one essential component of the assessment for the accreditation, and other approach to improve the quality of TB service is to have the coach and champion program, together with the health professional organization, the coalition of the health professional organization, and also with the we do initial engagement of big chain hospital. I think it was some of them already mentioned also by sorry, I forgot, Dr. Was, yes, in his speech. So for the fourth strategy, we do strengthen the implementation of mandatory notification. We try to develop regulation related to mandatory notification, and actually we already have the regulation. It is also clearly stated in our presidential decree, but we need like to promote it and to remind all the related stakeholders to do this, and also we conduct we try to do the interoperability of all relevant data system, including with the national insurance system. So number 5, we do strengthen the PPM, the district public-private mix, because as I mentioned before, the health is decentralized in Indonesia. And also we promote the engagement of the private sector. We also support free and easy access of private patients to the diagnostic, and also deploy efficient sample transport system. And also, the last but not least, we do a linkage between private providers with community initiative for treatment supports, contact tracing, etc. Because private providers, sometimes they don't have, like, if we compare it to the primary health centers owned by the government, we do have cadres, we do have sub health center, etc. While private providers might not have it, so we do the linkage between them and the communities. So we do have some progress in PPM, as you can read in my slide. It's not perfect yet, but we are working on it, like with all our hearts, and hope we can achieve better for this PPM to achieve the TB elimination in 2030. I mean. So I think that is my last slide. I'm sorry for the internet glitch I'm facing here, and thank you once again for the opportunity, and over to you, moderator. Thank you.
Thank you very much, Dr. Pakasi. That was a very in-depth presentation on progress in Indonesia and what steps you've taken. Very much appreciated. So I'm stepping in again. Of course, these are difficult times. There are technical difficulties across all of us. We are connecting across time zones and across oceans. So it's bound to happen. Guy Stallworthy will reconnect in a bit. He's also facing technical challenges. So I will hand back to him, and once he reconnects, let us now move to the next speaker. We are pleased to have with us Dr. Basharat Khan, monitoring and evaluation specialist from the TB program in Pakistan. Thank you so much for joining us, Dr. Basharat. And if I can ask, very good to see you. And we look forward to hearing from you on the work that Pakistan is doing on strengthening MNE and also building accountability. I look to my colleague E to share your slides. You mentioned that you have difficulties. E, do you
Thank you
have
so.
the presentation?
Yeah, thank you so much. Thank you so much,
Monica,
Monica. Is it okay? Can you hear me, please?
Yes, we can. Yes, we can hear you.
Great.
Um,
So, yes, I'm sorry to joining late because I was engaged in another meeting which is held in Karachi, and I am in Karachi, one of the provincial capital of Pakistan here, for a health information system strengthening meeting organized by the ministry. So I was a bit late from that meeting, and I just joined it now. And regarding this, there are not many things going on at the moment in the country, as you know very well that on one side we are struggling with the so many things, and there are a lot many opportunities as well coming into it to strengthen our efforts here. And we are really thankful, Monica, your team, and everybody who are organizing us and who are actually helping us and enabling us to enrich our experience sharing across the countries, though in the time of this pandemic, and through these online meetings. And they are very helpful for us. And thank you very much again. So regarding this PPM scenario in Pakistan, we have a very important and integral ever expanding part of component of the PPM in Pakistan, and we really appreciate that. So far, we have a significant proportion. You can very well see on the screen that at the moment we are having more than 11,000 GPs intended to be on board in this year, 2022. I mean, next year are only few days after this year, and then we are expecting to scale up the NGO run BMUs to 158. They are the reporting BMUs at the moment. I'm sorry. And then this large private hospitals, a network of 56 hospitals are there reporting to us through the private sector. And then another model, which is the PPM4 model, and which is basically comprises of the non-health public sector facilities, which are not formally into the health system, health sector, but they are part of the health sector in addition to the regular health sector. And there are 80 facilities there. And in addition to that, this is a unique, innovative sort of pharmacies engagement in Pakistan, and it has been piloted in 4 districts of the Punjab province. And through the Pasi Foundation, they have engaged 2,000 pharmacies to track back and trace forward the TB patients registered at the pharmacies. So you can see that there's a very good structured, significant network of the PPM facilities in Pakistan. Next, please. Next, please. Can you go to the next slide? At the same time, okay, it's okay. At the same time, we do have the diagnostic services like microscopy centers. There are more than 400 microscopy centers associated with the GP clinics to carry out the microscopy, sputum microscopy. And not only that, we do have the 15 almost gene expert sites in the private sector, supported by 53 CAT4TV digital X-ray units, and 1 culture lab and 2 labs with DST facilities in the private sector. So you can see that we have that again very sort of good diagnostic facilities in the private sector. But we understand that they are not as much as they should be, keeping in view the expanding private sector in future. So there is a lot more need to have more diagnostics services in the private sector. Next, please. Can you hear me, Monica?
Yes, we can hear you. Yes, we can.
Okay. Okay. So I think the display of slides is not there. I can, if I can, should I narrate from my side?
Yes, please. We are on the slide public versus PPM TB case notification.
Great, great, great. Here I am. And so this is a sort of contribution. You can see that we started in, if we, I mean, draw a plot, and we can see that in 2018, it was 38%, and in the year it gradually was increasing, but suddenly you can see that the public sector during the COVID drought, but surprisingly, and very sort of, and it is a very encouraging picture that surprisingly this private sector it increased regarding the TB case notification in Pakistan, despite the COVID situation. That shows that the private sector was in that time of crisis was maybe capable to deliver and to notify cases despite the lockdowns and multiple sort of diverting of healthcare services in the public sector, which were there. Understandably, it is low in public sector, but in private sector it was high. But maybe subsequent to 2020, if you can see in 2021, there was a slight dip, maybe showing the aftermath of the COVID, and in the next few quarters, you can see a little bit dip, and public sector is rising up to in the post-COVID scenario. So this is the picture which is here, and it need to be understood more because experts are here. Next, please. Thank you. Now, if we further disaggregate the PPM interventions in Pakistan, you can see the data trends. If you can see clearly, and then I can translate this plotting of this TB case notification in PPM 1 model, which is the DP model, PPM 2 model, which is the NGO run model, and PPM 3, which is the private hospital model, and PPM 4, which is basically the non-health public sector or parastatal. So you can very well appreciate from this graph that the significant rise of TB case notification is reflected in the PPM 1 model, which is the NGO, GP model, and the least, I would say, it is almost static, which is the PPM 4 model. And PPM 4, which is parastatal, and that is, I would say, I would reiterate at this point in time to the experts that this is a missed opportunity we should take care of. The non-health public sector is a very structured, very organized public sector, but maybe this is less focused, and this is maybe so far not focused too much, but need to be focused more in the future. And this is a missed opportunity that we can have not many cases there from the PPM 4 model, which is the non-health public sector. Next, please. Okay, so I just an overview of the pre and post COVID impact on TB case management, and you can very well see that there was an overall decline of the TB case notification in the country in DSTB, about approximately 17% decline as of the notification in the year 2019, and similarly approximately 34% decline of the DRTB cases in the year 2020 as compared to that of in 2019. And also the TB HIV screening was also impacted in the in the post-COVID, rather in the COVID era. So we can say safely that COVID did impacted our TB case management in the country to a larger extent. Next, please. There are issues and constraints which I have been focused the issues and constraints regarding to the PPM sector. And these are the issues which need to be focused by the stakeholders and by the leadership at the country. The one is the disproportionately high notification of the clinically diagnosed TB cases in private sector, which need to be focused and which has been discussed in detail in the previous interprovincial meeting held in the country. And all the public and private sector stakeholders were there. There is a high notification of clinically diagnosed, and where a very low proportion of bacteriologically confirmed TB cases reported by the private sector. And next is the low referral of the presumptive by GPs for expert testing. So it has been observed that despite having that expert machines availability in every district, or rather beyond district, below the district levels, but the expert testing is very, very, very low in the presumptive referred by the GPs for testing. And then maybe there is an awareness to be created among the GPs, and that complete database of the expert sites and with their telephone number and focal person, maybe a small directory maybe designed or devised for the GPs, which are approximately 17,000 very soon, to refer those cases for expert testing, and we can touch those missing TB cases, which are a big problem for us. And next is the compromised capacity of the private sector to implement NTP guidelines. GPs don't tend to follow that case management, TB case management protocol, which is basically given by the NTP, and they don't, not all, but some of the GPs, they don't tend to follow the algorithm for diagnosis of the presumptive also. And that is also need to be strengthened through repeated capacity building activities and close monitoring of the GPs. And then is it the ownership issue, especially among the chest specialists and more especially in the tertiary care hospitals, basically which are not following or adhering to the NTP guideline for the TB case management. And next we come to the similarly DRTV notification in private sector is pretty low due to limited capacity of the private sector for the DRTV case management, because among the existing 31 PMDT sites, there are 1 or 2 PMDT sites in the private sector. And I think that if we take again this opportunity to establish the PMDT sites more in the private sector, large hospitals, which are large private hospitals, it would be easy to actually not only to find the missing TB cases, DSTV missing cases, but also the DRTV cases also. So this need to be focused also. Big private hospitals to be equipped for PMDT facility as well as the expert sites. Okay. Next, we come to the low TB preventive therapy and household contact management in private sector. It is again a gray area, and we need to focus more into it. And we requested our stakeholders, private stakeholder, to focus on it. And then comes the low preventive TB therapy, effectiveness of the system for yield of the TB cases through active case finding. We need to have an operational research again on this, and that need to be explored, that whether the ordinary chest cams give a cost sort of benefit yield of the TB cases through the active case finding intervention or not, or we should adopt some other intervention to make it an effective intervention, or maybe this intervention should be performed in the nearby the tertiary care hospitals, or maybe it should be applied to the hotspots to be identified through the geographical mapping of the area. And these are the issues with specific sort of reference to the private sector. Over from my side. Thank you so much.
Thank you very much, Dr. Karpai. I hope everybody could hear me okay. Sorry for my system problems earlier. So now time is going by, so we're going to move on to our next presenter, Dr. Chukwuma Anyaika from Nigeria, please, to give your presentation. I'll ask both of the final presenters to try to move quickly through your slides with a focus on the issue of the data and the monitoring indicators, and again, encourage people to pose the questions in the Q&A. I know our panelists are responding to them as we go. Over to you, please, Dr. Anyaika.
Yeah, good afternoon, everyone. I'm pleased to be part of this meeting. Please, can you quickly look my presentation? Yeah. For want of time, can you go to the next slide? For the want of time, I'm going to take this presentation following the outline, Ppm trend in Nigeria, engagement strategies, monitoring system, accountability framework, National Strategy Plan 2021 to 2025, and then I'll conclude. Next slide. Yeah, it's very important for us to know that 60% of Nigerians seek for help at the private health facilities. So luckily for us, we had to leverage on the first strategy of the global Stop TB strategy, which is to engage all health providers using public-private mix. And we also realized, because we have several players on the PPA private sector, we have the private for-profit, faith-based, and then the communities, the community pharmacists, and the community private vendors. And so because they have different ways of operation, so we have to engage our strategy, not one style that fits all. And so we by our engagement that came up significantly last year, realized that even the increment we made on our case notification was majorly from our strategy towards expanding to private health facilities. And that gave us to 26% of our national case finding for 2021. Next slide. Next slide, please. So what strategy did we use? No, get back, please. What strategy did we use? Our plan was to enroll all private practitioners, private for-profit, faith-based, private medicine vendors, and community pharmacists, because we realized, especially the community pharmacists and private medicine vendors, that the first port of call for people in the communities. Then for us to track our whatever they're doing, we had to invent the use of a mobile app for easy screening and reporting of PPMs, and for our national drug repository channel. Of course, we had to invent the incentive method through and then sending a MOU with the implementing partners at the community levels. Next slide. Next slide, please. Then by the end of our end review of our 2020 plan, we found out that some gaps which which we also impede our achievement towards the private sector. We know that most of them are not invested in diagnostics, and then treatment follow-up was also not optimal. And also we found out that they were not, most of them have the problem of not giving giving the correct prescription and inappropriate discontinuing of the treatment drug. So what we did was to engage and capacity building, sharing our SOPs and following them as the case may be to ensure that they do the right thing. Despite the fact that we give monetary incentives, we also follow up to supporting supervision and mentoring to make sure that they do the right thing according to the national protocol. Next slide. Next slide, please. Next slide, please. Hello. And so because we've noticed that most of them were not capturing what they were doing at the private health facilities, we had to work on trying to get whatever they're doing, the data into our national data reporting channels. So the private health facilities they are all in the communities, and most of them are in the local government, which is the lowest, cadre in our system. So the data moves from local government to the state, data system, from data system to the national, and with that, we'll be able to look at what is happening and be able to triangulate and know where the issues are. And then we now compare it with, merge it with the national data from the public health, and that we use to really evaluate what we are doing at the fatality levels, and then to be able to evaluate what we are doing at national level in terms of case detection and the treatment and returning them in care for absolute cure for as a strategy for cutting the chain of transmission in the country. The overall goal is to fund it towards kicking out tuberculosis in the country. Next slide. Now, this shows our PPM monitoring, accountability framework, in which we have our commitments according to SDG 3, and also the NTB strategy and associated milestones and targets adopted in Nigeria. So what do? We have to, work, make sure that we include the PPM actively in our National Strategic Plan of 2015 to 20, and then to even revise that, to put actively in our next strategic plan of 2021 to 2025. Then we also have to, also look into our AP analysis and other thematic review. Then, what we want to achieve at the end of this is to make sure that the routine national program, TB recording and reporting is put in place, and quarterly and annual national reports are also evaluated, and annual reporting to the WHO, Global Fund, and other funders, USAID and other stakeholders that send money for TB intervention in the country. Also, we share this data with the National Council on Health, which gave us a shown that there should be compulsory TB treatment and notification at all facilities in the country. And with that, we'll be able to seek for domestic research mobilization in the country. Next slide. Next slide, please. No. Can you get back? So for the 2021 to 2025 strategic plan, we also captured the need to improve our TB quality of care at the private health facilities. We also work towards ensuring that we keep to our targets. Although our target for 2025 was for the private health facility to make up to contribute at 5% of our case notification, but we have realized that we may need to revise that, because even as at last year, 2020, we have already made 26%. So we are thinking that with our huge investment towards private sector, we'll be able to, we're on the road towards increasing case notification in the country. Next slide. So the next, we're talking about improvement in the concerns enumerated by the end-term review. The private sector providers are now employing diagnostics, treatment, and follow-up according to national protocols. We also realize that most of them may not have the financial muscle to set up diagnostic platforms. So the national program is working towards making sure we put up a standalone diagnostic platforms at the healthcare and the private, suitable private healthcare facilities for us to track, the missing cases in the country. So now we report TB cases in the national TB program using the electronic platform, so I'll be able not to miss, have a lot of the cases missing up in our reporting tools. And we also, with the training and retraining of the healthcare providers at the private healthcare facilities, also, we have noticed an increment in adhering to appropriate case holding and also making sure that appropriate treatment and ensuring that we do not lose track of the patients and to keep them on treatment till the end of the regimen. So with this, we are thinking that we will be able to make a very huge impact on case notification, retention in care in the country. Next slide. So in summary, the national program is committed to further strengthening and improve PPM system using the best practices gathered during implementation. Monitoring and evaluation of learning has also been instituted to gather accountability. The accountability framework will help monitor instruments into the PPM strategy. We just finalized our revised PPM strategy and guidelines in the country, and we are working towards ensuring that all the private healthcare facilities in the country, including the traditional healers, the private medicine vendors, community pharmacists, and faith-based, and even private for-profit are all covered in the country, since we've realized that 60% of Nigerians seek help at the private healthcare facility, and that will also help us to increase our case notification. We have also engaged on our awareness creation to ensure that we'll take care of stigma and discrimination at the private healthcare facilities. And with all these, Nigeria will be on a sure way towards increasing our case notification and returning them in care towards our kicking out tuberculosis in the country. It is very important for us to know that also our treatment rate in the country has also risen to 87%, and we hope that with all the strategies in place, we'll be able to cut down the scourge of tuberculosis in the country. Thank you very much, and over.
Thank you very much, Dr. Nyaka. It's great to see such recent progress on TB in Nigeria and on private provider engagement in Nigeria in particular, thanks to everybody's efforts. So we're running short on time, predictably perhaps. So we're going to turn now to the final presentation. Dr. Afzalur Rahman from Bangladesh, please, for your remarks about PPM and this issue of monitoring and accountability. Thank you.
Could you please unmute yourself?
Hello. Good evening, everybody, and also good afternoon. I am Dr. Afzalur Rahman from Bangladesh National TB Control Program. Public-private mix and monitoring in Bangladesh. Next slide, please. Bangladesh is a small country in South Asia and densely populated, more than 1,000 per square kilometer, and we have 8 divisions and 64 districts and 491 sub-districts and city, corporation, and municipality. Next. Next, please. Bangladesh is a high burden TB country, and its incidence rate is 218 per 100,000 population, and estimated burden is 360,000 per year, and mortality is 27 per 100,000 population, and incidence of MDR is 2 per 100 population, and absolute number is 3,300, and laboratory confirmed MDR is 1,113, and XDR is, or pre-XDR is 67. Next, please. Next slide, please. Next slide, please.
Sorry, I think there may be a lag in moving the slides. Okay.
Okay. Bangladesh PPM. Bangladesh have a strong PPM, and we have diverse partnership, and we have NGO consortium consisted of more than 25 NGOs. And National TB program coordinately work throughout the country, and we the largest NGO is BRAC, and this map show a pink area. In this map show pink area shows where BRAC work, and another large NGO is Damien Foundation. This orange area they work, and HEAT Bangladesh, this gray area work, and other small NGOs. We work together, and civil society, we also works with civil society. Especially in the World TB Day, we are sit together and discuss. And medical college hospitals include government medical college hospitals and private medical college hospitals. We have a network, and specialized hospitals, institution, and armed forces medical armed forces hospital. Also we have network, and development partners. You know that USAID and other development partners have here project like ACTB project. They works with us, and especially in PPM sector. And professional association, especially we work with pediatricians and also physicians and surgeons, and periodically we sit together. And corporate sectors, especially, you know that we have big garment sectors, and their BJME and BKME is their association, and they actively work with National TB Control Program, and in workplaces they actively screening out TB patient. Next, please. And public-private mix implementation model. NTP and partners have implemented relevant engagement PPM strategies that include hospital services delivery or dots corner model. You know that Bangladesh has about 491 sub-districts level government hospitals, and there are dot corners there, and this government hospital, in that hospitals, NGO workers actively working with government staff. And in private hospitals, there are private hospitals and government supply logistics and equipments in private hospital also. Engagement of graduate private medical practitioners. There are many private clinics in Bangladesh, and we have government and NGO field staff who go in private clinic and chamber, and we have a good network with them. And TB diagnostic centers in private sectors, you know that there are in many private hospitals and in private settings, in NGO settings, we have TB screening and treatment centers, and government National TB Control Program supply equipments and logistics there. Informal healthcare providers models, and we have village doctors and pharmacy and drug sellers. We National TB Control Program periodically train them and have network with them so that they can improve their skill and report us. And another big model is Shastro Sevika model. Shastro Sevika is a Bangla word. It means healthcare provider, and they are volunteer and they get some incentives from the program, and they have a huge contribution in TB screening, and they are mostly female workers in community, and they are periodically trained by National TB Control Program. And another is worksite model. Worksite model, I earlier mentioned that Bangladesh has a big garment sector. We are works there, and there are some medical officer and health workers who are engaged by them, and we also mobile diagnostic van, mobile van, and this mobile van also goes to factory to factory for screening of TB patient. And TB in prison, we work there with, the prisons are under Ministry of Home, and we collaborate with them, and they give them access there, and and our worker periodically go there, and they have also doctors and some health staff, and our Ministry of some staffs and doctors from the Ministry of Health also provide doctors and doctors for prison. They work there week for example 1 day per week. Next slide, please.
Dr. Rahman, if I may, I'm sorry to interrupt, but we're running over time. If you could quickly move to the slides on the monitoring indicators, that would be excellent. Thank you.
Okay, thank you. Next slide, please. Next slide. Can you hear me?
Can you move ahead to the monitoring indicators?
Yes, we can.
This is the, can you give slideshow?
Yes, we see the slides, Dr. Ahmed.
Monitoring, we have national PPM committee, PPM working group, task force for mandatory notification, different coordination meeting, including partners to monitor, and PPM activities like MNE working group meeting, PSM working group meeting, laboratory working group meeting, urban TB working group meeting, and on-demand meetings to engage PPs on concurrent issue. And these meetings happen regularly in TB program. Next, please. NTP has PPM focused indicators for case notification that is being reported, referral from graduate PPs, referral from non-graduate PPs, and referral from private hospitals, and referral from government hospitals. We have all record, and we also introduced ETB Manager, which is online data reporting system. And partners also report referral through professional organization or workplace. NTP tracks SBCC activities conducted by partners, and NTP annual report includes partners' activities. Next, please.
Thank you very much, Dr. Rahman. That's a great overview. I'm sorry we had to, we ran out of time, but I think the audience saw the quality and the richness of the data you have. So thanks everybody to our presenters. We're sorry we didn't have time for enough back and forth and discussion. There were a number of questions posted in the Q&A, and the panelists have responded, so I encourage you to check those. I think in some we see great progress in a number of countries, good data on notifications. In some cases, we're seeing data now on the coverage of private providers, how many are there and how many are participating in different ways. I'm hoping that with this initiative from WHO in the next meeting, we will see much more data on patient pathways, on the quality of care. We didn't see any data on outcomes, for example, amongst private patients. Of financial protection amongst private patients. This is a critical issue. And indeed, the investments and the level of effort that we're putting into this area. So a lot to look forward to maybe in a year from now. And in the meantime, very encouraged to see this initiative from WHO to work on the indicators and dashboards in this area. So Monica, with apologies for going over time, back to you for the rest of the event.
Thank you, Guy, for moderating an excellent session. Yeah, it's good to, and also thanks to all the speakers from countries. It's indeed a topic that requires an investment of a lot of time, because a lot of work is ongoing in countries, and we really look forward to working with all of you to strengthen monitoring, evaluation, and accountability, and we will be in touch. So thank you so much for that, Guy. I now turn to the next session. We now have a very special spotlight on addressing drug-resistant TB in the private sector as part of the overarching antimicrobial resistance agenda. So for this, I turn to the Vice Chair, Dr. Lal Sadasivan. Dr. Lal, over to you for leading this session.
Thank you, Monica. So we have just 15 minutes for this session, right, Monica?
I think we can go a little bit over time. So
Okay, yeah, thank you. So it was just 1 week ago that we concluded the 1 week observation of the World Antimicrobial Awareness Week, which we do every year from 18th to 24th November. So this year's theme, spread awareness, stop resistance, called on One Health stakeholders, policymakers, healthcare providers, and the general public to be antimicrobial resistance awareness champions. WHO has declared antimicrobial resistance as one of the top 10 global public health threats to humanity. Irrational use and misuse of antimicrobial medicines, especially in settings where private sector is large and largely unregulated, continues to be a serious problem. So we are witnessing excessive use of antibiotics due to COVID pandemic also. And we know that the cost of antimicrobial resistance to the economy is really huge. So in this session, we have two presentations. We have only 15 minutes. Monica says it can be slightly extended. We need to strictly adhere to the time allotted for each presentation. I would like to invite Salika Fatah for the first presentation, Overcoming Drug-Resistant TB by Anta. She's Salika Fatah, who is an MDR TB survivor from Indonesia. Salika, the floor is yours.
Hi, hello. I'm Faradiba. I'm 26 years old and I'm a 3-time TB survivor. I'm also currently a medical student and I'm a member of an Indonesian Youth Coalition for Tuberculosis. I'm the only daughter in the family. All my siblings are boys who fully supported me in my treatment. Overcoming TB, which means talking about sacrifice to my dream, which was delayed for a very long time. Even still having an impact, I lost friends, my targets were a mess, my focus was divided, my life was only limited to boarding houses and hospitals for 3 years. I have a quite interesting experience regarding PPM services providers because I have experienced both, but there is a big hole that we need to fix it and complete the missing things. When I started experiencing symptoms of TB, I was 21 years old. I came to a private hospital in a small town where I live, but not far from the capital, because I thought I would get the right diagnosis, but the diagnosis could not be made. It was enforced until the second week I was treated. Then I was diagnosed with drug-sensitive TB through X-rays. I immediately underwent TB treatment. Strangely, there was not significant change. So I decided to leave the hospital. I was seeking advice to one of my lecturers to answer my questions. What's wrong with me? And the first time I met him, he already suspected that something was wrong. It was not an ordinary TB. And I referred to a private hospital, which was quite large. And I did a lot of tests, including gene experts, etc. And it was proven that the result was positive. During this initial treatment, I used my insurance. But what about people who doesn't have enough in their pockets, as Rhea say, and doesn't have insurance to cover the bill, or even cannot reach their nearby hospitals because they live in a remote place? How desperate they were to seeking treatment and advice. There is no partnership between the public and private sector because I didn't get any information about TB in private hospitals, only from link to link. And TB really changed my life, my school, and everything. I was overwhelmed, drained, my energy, money, mentally, physically, but above all, I had lost my golden era. To overcome TB requires a complete package, the right and effective policy. We need act from all sectors, and we must not be missing is a strong support system. My mother was my caretaker when I wanted to kill myself by skipping treatment, and I realized that the risk and everything, she brought me back to my sense and made me to undergo this treatment again until I got XDR TB. My supportive family took me every day through a 2-hour drive just to a medicine and back home again. My time was up to finish this. You can imagine if the TB services was as fast and easy as COVID. Information was everywhere, especially social media, different platforms, applications to make it easier for patients to access. Why don't we do the same thing about TB? What if COVID can link TB in their apps or vice versa? So COVID patients can get information about TB also. It is our time to be more serious and educate from the most basic things with simple but clear and firm language to reach the lower middle class people because they find it difficult to understand the information and ineffective diagnosis that has an impact on the high resistance itself. Access and services that should have close communications in order to eliminate TB both in public and private hospitals. And in my opinion, private hospitals also play an important role. So to be a champion, there are many people who play a role behind it. I can do this alone and you can't do this alone too. We must be able to become a solid team to make us win a battle against TB. As you know, the WHO program, 1+1 initiative, is a great thing to do. And I did this in my social media. They shared their own experience to strengthen each other, engage them, spread positive thoughts, and try to change their perspective on TB stigma and discrimination. Even though I never met them personally, we must prove that TB is no longer underestimated. We must fight for their rights and improve in every aspect, especially access to experts, listen to what they need, and do is as effectively as possible. TB is as critical as COVID. That's it. Once again, I would like to thank Dr. Teresa Kaseva and Monica, who gave me this opportunity to be able to join this important event, who always encourage me to speak and be confident to fight TB. Okay, thank you. Over to you.
Thank you, Salika, for sharing your experience and your interest in fighting TB. Actually, it's really sad to see that despite all our global efforts to eliminate TB, still we have issues like this, what is being presented by Salika. And your experience actually re-emphasizes the need for engagement of all sectors in all high-burden countries, especially the private sector engagement. Congratulations to you for all your work and for your presence today. Thank you.
Well,
and the next speaker is Codlin from Vietnam. The topic is assessing the burden of drug-resistant TB in the private sector in Vietnam and innovative approaches to scale up to care. So Codlin, please.
Thank you very much, Dr. La. Can you hear me and see my slides?
Yes, yes.
Great. First off, I wanted to say that it's an incredible privilege to present today along with all these distinguished speakers. And thank you to Monica, the team, and everyone for having me. And especially thank you to Farah and Ahanda, the survivors, for sharing their stories. Those are incredibly inspiring. And really what we should remember is why we're doing all this. So I'm going to talk a little bit about assessing the burden of drug-resistant TB in the private sector in Vietnam, as well as innovative approaches to to scaling up that access through our proper care in the private sector, or PCPS project. And I am aware that time is of the essence, so I'll try to keep it short. So we work in Vietnam. Vietnam has about a treatment coverage gap of 42% and 172,000 incidents. That means that around 70,000 are currently unreached by the NTP, of which roughly half, so 35 or 10 to 20% of total is underreported, and then another 10% is perhaps underdiagnosed. When you look at PPM performance in Vietnam, it's been similarly suboptimal, if you will. And this is a chart from 2020. The previous years were the same, where we pretty much have a 10% or 12% contribution from PPM, of which actually only 3% are really from private sector. The rest are from other non-NTP public sectors. But when you look at the landscape of PPM in Vietnam, and on the left side here in the middle, you have the core TB care and prevention network, but then around it, you have whatever you have in other ministries, like, and I've circled the key players here, for example, the military medical university under the Department of Defense, or under the Department of Public Security and Police. Those facilities, those that belong to super ministries, as they're called, they are usually not the first ones to collaborate with the NTP, even if they're asked. On the right side, you have everything within the Ministry of Health, but outside of the TB program, and particularly the national level hospitals that are directly reporting and part of the NTP, part of the Ministry of Health, that again are not underneath the NTP and have problems working with, as well as all of the private players in this field. But when we look at that landscape and the complexity, we have to remember that in the NTP itself, there is one part-time director and 2 full-time staff that are supposed to navigate that landscape and then navigate all these numbers of providers. And then it's not a surprise that it's difficult to reach all of them, when especially that, which then means that there's actually quite a bit of lost opportunity left on the table in terms of engaging people persons with TB. And that's particularly, as I mentioned, in the non-NTP public and private hospitals, the private providers and clinics, as well as the pharmacies and drug retailers. So what we've seen in India, and I want to give a shout to a colleague from Shibu Jain, who's worked on this for a long time, but that intermediary agencies can actually work really well to close coverage gaps by proposing a tangible value to these private providers, increase the integration in the TB care and prevention activities in the country, and then actually result in sustainable, near-term, immediate almost, but sustainable increases in TB case notification. And so we try to emulate that in Vietnam by establishing what we call the PCPS model, or also just the PPSA, a private provider support agency model, around the local context where there is no WHO recommended rapid diagnostics available in the market, or there wasn't, and that engagement, there were barriers to engagement of social health insurance, so that PBIs would work, performance-based incentives, and try to bridge the gap between these providers and what they believe they need to meet their business objectives, whether it's patient relief, retention of clients, revenues that they generate, or in the end, support and reporting and respect and recognition, to what the National TB Program believes that they need in terms of meeting their public health goals. So receiving referrals, notifications, greater transparency into the burden, greater diagnostic quality and back confirmation and treatment quality, et cetera, et cetera. And ultimately, as all these countries are moving towards more of a diversified portfolio of health financing, the health sector or the private sector can be play a critical role to bring around that relief. So what we try to do is we try to emulate that model and a lot of its best practices from the model in India, but also from industry, leveraging systems like the customer relationship management tools that we have that are freely available, leveraging a dedicated sales force to build the network of private providers, and have built and go through a process of mapping them rigorously, engaging them continuously, and then signing contracts with, whether it's, as you can see on the lower right, pharmacies, the majority of them, or hospitals, doctors, and so forth, and then do the analysis based on these data to look at how many. So as you can see, pharmacists constitute the highest numbers of contracts signed. However, the most referrals come then from hospitals, yet all forms TB detected actually come a lot from private doctors and their private practices, as well as informal providers. So that level of analysis in order to optimize the network of clients that you maintain. And so in our model, we basically have boiled it down to two engagement strategies, really. One is the diagnostic referral strategy, and one is the private reporting strategy. In terms of diagnostic referrals, I'm showing you results year to date for 2021 from January 1st until November 29th. And you see that we have the system called ACES, developed by Chai and Vietnam, DNTP ourselves, and TechUp, that has recorded 111,000, 112,000 verbal screens, X-ray screens, and so forth. But the key point here is, what does drug resistant in the end look like in the private sector in Vietnam? As you can see here, Drtv rate amongst those diagnosed was roughly 5%, which is actually what we know from the latest, from the fourth drug resistance survey, is kind of on par with that. And as you can see in the last pie chart, is that once we diagnose and detect these patients, a lot of them, a good quarter of them, actually decide to receive and continue to stay in the private sector rather than go to the NTP for treatment, which is you know, part of the natural the market that's always been there, that we know it's always been there, and now we need to find a way to tap into it. In terms of the second strategy, the reporting strategy, as you can see, we are in 2021, we've engaged 29 private providers who and doctors that work in hospitals but moonlight, that are part of the NTP but have their private practices, and they received actually 3,834 case level data from individuals who are receiving private TB treatment. And what we're doing with them is, if we receive these data within the first 2 weeks, we try to collect sputum to do rapid molecular diagnostic tests to increase the back confirmation rate and the diagnostic quality, because before that it was a large part relying on clinical diagnosis. But then, as you can see here, amongst those reported, and again going back to the drug-resistant TB topic, amongst those reported in private sector treatment, the rate was actually quite low. It's only 1.6%, or 1% of the total number of persons treated, because what we found out is that in the private sector, on private sector treatment, private practitioners aren't, especially if they're general practitioners, aren't super keen on having drug-resistant TB patients in their waiting room amongst with their other clientele. So that's another opportunity to perhaps optimize and perhaps develop the Ppm, PMDT programs in the private sector in Vietnam. And what have we seen once we've started collecting all these notifications and started doing all of these referrals? And as you can see here, it's just a basic comparison between the first half of 21 versus the first half of 2020. And you see that even though we were implementing only in 19 districts in 3 provinces, Hanoi, Ho Chi Minh City, and Haiphong, compared to the remaining provinces, there was a significant, substantial increase amongst the Ppm notifications that actually showed a 41% increase at the national level if you look at Ppm in total, and 163% or 64% if you're looking at just the private sector notifications. So just to sum up, the key results was a substantial number of providers engaged, a lot of facilities, especially large hospitals like the Tropical Diseases Hospital or ministry level hospital, or as I mentioned, the Ministry of Defense hospitals from the Ministry of Defense and Public Security, do screen and do find a lot of TB persons with TB who they are more than willing to transfer, and they already collaborate. This is something to note. They already collaborate, but if they find 100 cases, they will notify perhaps 20, and then the rest they will either treat themselves or take back to their own private practices. But by engaging them, offering a tangible value proposition, you can actually collect these data and then provide them to the entity for notification that results in a real impact on notifications themselves. And going beyond the project, what are the policy considerations for TPM in Vietnam? And there are 3, there are a number, but I've listed 3 main ones quickly to mention. There are to reform the PPM law to enable these private sector notifications, to improve the implementation, because the policy exists, but the implementation is poor, off the mandatory notification law. And lastly, to reconcile differences like the law on social health insurance reimbursement, that in one law it says private providers can receive reimbursement, and then in this law, in this particular circular 04, it says that they cannot. And so reconciling those in order to remove barriers of access and barriers to participation. But this is all just from a project perspective. This PPM platform and this private provider platform can also serve as a platform for innovation, for integration and policy reform, as I've mentioned, from our pilot that happened only in 2 districts in 2017, 2019, developing the XX or X-ray expert algorithm, trying the CRM, assessing VOT in the private sector, to the current efforts of using SwipeRx, of engaging pharmacies through a professional network platform, or using batching and outsourcing of sputum collection and transport through rapid shipping providers like Grab, like Uber, things like that, and then deploying AI surveillance in general hospitals to see if we can just passively, actively capture any persons with chest array abnormalities that could be presumptive TB. And that, all of that can then lead into the future, where this has been picked up by the NTP and scaled up through global fund financing, or will be this year until the 2023 in 10 provinces. But overall, with the idea of creating a platform and a network where we can try new things like TB and comorbidity or multimorbidity integration, reverse integration of TB screening in other public health areas such as endocrinologies, hospitals and so forth for persons with diabetes and so on and so forth. And then expanding access, not just for the patients, but then also for the health system and TB programs, to multimodal health financing and multi-sectoral engagement opportunities like the work that we're doing with the Ministry of Defense, the Ministry of Police, the Ministry of Transport, and that also has a hospital. So expanding the opportunity for multi-sectoral engagement and collaboration. I would like to just quickly acknowledge TB Reach and the Stop TB Partnership, USAID, as well as the Global Fund, CDC, and CDC Foundation for their generous sponsorship, our partners, the National Lung Hospital, as well as the Provincial Departments of Health and Lung Hospitals, as well as the entities at the district level, our clients, who are these private and non-NTP public providers, and of course, at the end, never forget our purpose of why we're doing this. Thank you, Farah, thank you, Hannah, and thank you all of the health-seeking persons with suspected and confirmed TB. Thank you so much.
Thank you, Cordin, for the great presentation. Yeah, so Vietnam has a long history in PPM, and we also know that the health system is very complex in the country. And it's good to see that there is cross-pollination. We are referring to what was happening in Mumbai and what can be copied in other countries. So, good experience and good lessons from one country to another. So those who have seen both the cities, Mumbai and Ho Chi Minh, we can see a lot of similarities also there. Very complex health systems and a lot of players in healthcare. So, and the message is that, of course, we realize that there is increase in case notification with your project, but the take-home message is that there's a lot of work to be done in countries like Vietnam and similar high-burden countries. Thank you again for the presentation. Monica, are we going to take questions or how is it?
So I think we're running out of time, but I see that there are questions in the chat. There are questions from Matilda and Bola, and it would be great, Luan, if you could respond. They're very specific to Vietnam. So maybe we could respond online. Would that be okay, Lal?
Yeah, perfect. Thank you.
Sure. Okay, I'll keep it short, Dr. Lam. So Matilda, your question is how are we able to pick data on referrals at the providers at the national level? We actually work with them to provide them with access to this ACES software and tablets, where they conduct the screening using a mobile app and a predetermined or pre-developed form that includes verbal screening, a basic intake of demographic data and so forth, in order to then work with them to follow up on the screening, on the testing results, all the way up until notification. So we work with these sites to furnish them and to support them on using an electronic data collection tool called ACES. Bolanle, I thank you so much both actually for the questions. Your question on supporting private providers to treat patients they diagnose. We actually do. We actually work with them, and And to be perfectly honest with you, the private providers at the moment, that was the second strategy. They do report patients and persons with TB that they treat themselves, but there's always the Pareto principle. A private provider that detects perhaps 10 patients, they keep 8 of those that can afford the treatment, they can afford to stay on and so forth, and those that cannot, they would like to refer them, or those with severe TB, those with drug-resistant TB, like to refer them to the ATP. So we work with them to link them to care, or to simply receive the treatment notification information. And as part of the work that we're doing with Stop TB at the Global Fund, there is patient support in terms of nutrition support, or vitamin support, and so forth, that we provide to patients that perhaps are at the lower levels of socioeconomic status. So again, I hope that answers your questions, and thank you so much to you both.
Thank you. Over to Monica.
Okay, thank you so much, Alal, for coordinating this session. And thanks to Luan and Farah for their presentation. So overall, a very exciting day. I'm just going to also spotlight Madhu here. So yeah, we're very happy. I think as we wrap up, just very pleased with today's session. It's been extremely comprehensive. Many thanks to those of you who've been able to stay throughout to listen to the presentations. As we said earlier, the recording will be made available on the WHO website. We will also have the presentations available for you, so please do have a look at that. So many thanks to all the speakers, the chairs who managed all the discussion and presentations today. A special thanks to the TB survivors who shared their experiences. Handa and Farah, you really set the human tone for all the work that we do, and make the work that we do really feel meaningful. So just looking ahead, we have an exciting day planned for tomorrow. It will start off with our chair of the PPM working group, Madhu Karpai, going out of the box, looking at innovations with a series of a panel discussion with a series of actors who are working on PPM innovations. We also have a special session on social protection, UHC, and overcoming inequalities. And we will end with an open forum. So please do join us tomorrow. We look forward to welcoming you back again. Please write to us if you have any questions or clarifications in the meantime. So very, very warm thanks to you all, and look forward to seeing you tomorrow.
Thanks, everyone. Thanks for joining us. See you tomorrow.